Hi, Letu, Shane, Lisa. Great to have you on board.
Hi, Shabir, how are you doing?
Good, thanks. Are you able to share any? I'll just make you co-host. I think although it should have allowed you, but never mind. If you have any presentations to make or any slides to share, Lisa.
Sure. So from my side, Shabir, not
no slides.
much. So I'll
Not a
just
problem.
be speaking more to the points that you raise.
Not a problem.
But both Lindsey, Lisa, and Letu have PowerPoint presentations.
No, it's fine. No deal. I think the conversation is basically as we try to just to explore possibilities.
Yeah, and just setting the scene also for what comes next.
Okay.
So just apologies, I'm on leave, and so I'm in a bit of a remote area up the northern coast. So my reception's not great.
The video will be a challenge.
Yeah, so
it's fine.
I should be able to stay on for most of it. But if not, I'll just keep reconnecting.
All right. No, that sounds fine. Yeah. So I think Lisa is it Lisa and who's presenting after you or talking after you? Is it Lisa, as I think we talked about?
So Lindsey will go first.
Lindsey will go first. All right.
Yes, and then followed by Lisa and Letu.
All right. Let me use that post as a way to do it. Yeah, all right.
Hi, Shabir.
Yep. Yes, go ahead.
No, hi. I'm just saying.
Hi, sorry. It's Lindsey. Hi, sorry. I was just looking at something else. I should have presented something, but all right. Let me just use this slide and we'll go for it. Yeah. Okay, well, great to have you all on board, and we'll just go. I'll just open the webinar now and just go on mute and open. Hi, everyone. My name is Shabir Musa. I'm a family physician in Johannesburg and the chair of the Johannesburg District Research Committee. So welcome to all of you for joining us. We're really pleased to have in our midst Dr. Prof Shane Norris and his colleagues. I'll talk a little bit about them just now and what is going on in the rest of the webinar. As we usually do in our webinars, share a little bit of what's going on in the District Research Committee itself, and to give you a sense of progress. I'm going to show you an overview of our progress as a District Research Committee. This is as of the 2nd of December, so it's just a few days old. But you can see from it that we have in fact had about 114 applications to the end of October, and that we've resolved about 87% of these applications. The pattern is very similar for November as well, that we are progressing quite fast. The waiting times that we have been able to get to is about 20 days or 19 days. And that's kind of where we're at in terms of moving along progress-wise. So I think that it's very useful to see that people are getting their research addressed in terms of applications to Johannesburg, and most of the problems that are a few months old are being dealt with. So we are in a position to get people getting their research addressed. So that's basically just a report on the Joburg DRC and where we're at. I'll just quickly introduce the team. Basically, we have Prof Shane Norris, who's basically going to talk a little bit about what is the possibilities, what's happening in his particular unit, what happens in the sort of University of Witwatersrand in terms of research units, and what are the major units, what kind of work do they do, and how can we look at possibilities for collaboration within Johannesburg between the DRC or the health district and these research units. We are going to get two presentations after that. Dr. Lindsey Dixon and Dr. Lisa Ware and Mr. Letu Kapweja will talk about some really important stuff happening within the DPHRU that Prof Shane Norris leads. So with that, I want to say thanks to Shane for Prof Norris for arranging the team to present. Shane, I know you are having challenges with your video, your connection, and so we can't see you. But thank you very much for making the effort to join us while you're on leave in the coast of Natal, KwaZulu-Natal. So thanks very much for making the time.
Many thanks, Shabir, and thank you for giving us the opportunity to share some of the findings that have come out of the collaboration with the District Research Committee and the work we've been doing in some of the primary health care clinics in Soweto, and Great. Also to share sort of where we see things going. So we're very excited to have this opportunity to feedback.
Great, no, appreciate that. I mean, you've been a professor of pediatrics at Wits and had 26 years of experience, research experience in that, and I think a lot of very seminal work that lots of people speak of. Do you mind telling us a little bit about the work that you do in your unit, DPHRU, and your background?
Yes, certainly. Yes, that'd be great. So Developmental Pathways for Health Research Unit is located in pediatrics at Chris Hani Baragwanath Academic Hospital. It's a joint unit between the South African Medical Research Council and Wits. Most of the work over the past, as DPHRU over the past over 10 years, and before that in working with John Pettifor and his unit has mainly been based in Soweto. So a long history of work primarily in the Soweto area. Right. DPHRU feeds into the maternal and child health agenda of the National Department of Health. All the MRC units are aligned to key strategic outcomes that DOH is focused on. So we fit in maternal and child health. Right. I think we bring a unique perspective on that, in the sense, not only do we try and understand shorter term outcomes around maternal and child health, but also to understand how that period, the first 1,000 days of pregnancy and infancy, even beyond that in childhood, or even before that in preconception, how that sets up these trajectories to later adult health outcomes. So in a way, we straddle between a long-term perspective and then a kind of shorter perspective around survival, child growth, development, and so on. So given it's quite a broad mandate, it does mean that we have a significant platform of different type of studies that we nest, both observational to try and understand population level effects, mechanistic studies trying to understand the biology driving some of these observations, and then more recently, quite a significant portfolio of interventions. So trying to understand how could we change or shift trajectories that not only give favorable outcomes in the shorter term, but lessen risk for non-communicable disease in later life.
Okay. So what have been some really major studies or findings? Do you want to mention any of them that you've done and that work has been done in Soweto that has had a big impact in South Africa, at least?
Certainly. So I suppose the study that's both the oldest and longest running and has had probably the most impact to date is the Birth to 20 cohort. So it's a cohort that was established just when Nelson Mandela was released from prison. So that was back in early 1990. And it's been following a group of about 3,000 mothers and babies born in 1990. They are now 30 years of age. The cohort is still active. We've just recently completed our latest data collection. And as you know, that as 30-year-olds, they've got children of their own. So we have a 3-generational cohort study now, which provides an amazing opportunity to not only looking at the kind of longitudinal elements of growth and development and health, but also trying to understand factors that drive it, both within the generation, but also now cross-generationally. The finding, it's had multiple impacts on different levels, but in the kind of maternal and child health space, one of the fundamental contributions the cohort results had was in connection to the importance of the first 1,000 days and the South African Department of Health's new strategic plans that were formulated in 2015 to kind of prioritize the first 1,000 days and shift several initiatives, both from a nutrition point of view, health, and early childhood development. And the finding that, one of the findings was that how growth within that period, so birth size, as well as subsequent growth in infancy, sets up the risk for non-communicable disease later on, hypertension, diabetes, obesity. The most significant finding was really around diabetes risk, in the sense that for every kind of 500 grams less than the population average, increased the risk for type 2 diabetes by 10% on a population level. So the average birth weight in Soweto is roughly about 3 kilograms, 3.1. So if you kind of looking at a low birth weight of 2.5 kilograms, that increases the risk of type 2 diabetes later on by 10%. But not only did birth weight matter, also how you grew mattered. And so irrespective of your birth weight, if you grew rapidly by gaining more weight than you would have normally for your size, that further increased the risk. And that added an additional 10 to 15% of risk. So that if someone was born, so cumulatively, if you were born slightly lower birth weight and put on rapid weight gain, anytime in that childhood period, you could have almost 25% greater risk of type 2 diabetes, independent of other factors, other critical contributing factors.
Well,
so that kind of really gave the evidence to show that that period mattered in programming, in setting up trajectories, and that crystallized the unit's focus, but also really helped government push some of its agenda to think, not only think of maternal and child health, particularly around the age 5 and the school-going years, but really shifting it back and thinking of the importance of infancy, pregnancy, and such.
How is that translated? I mean, I'm surprised. I haven't, I haven't seen any evidence of that in the public service, particularly. Perhaps I'm not well informed. What are the kinds of things that you've seen translated into programs that are being acted on in the public service in Soweto that changed this trajectory?
So I think the two more recent kind of initiatives that were born from government strategic plan set up in 2015, and shifting to kind of that earlier focus. Firstly is the focus of pregnancy. So they've adopted further WHO recommendations of more antenatal sessions during pregnancy. Sure. Slowly but surely rolling out services that are more introducing sonography and other abilities. We now have fetal growth standards. So not only do we have growth standards, but we now have fetal standards. And so making sonography more accessible, not just for dating, gestational age, but looking at impaired fetal growth is slowly but surely getting traction. Mom Connect, the ability to try and intervene during that period, is another part of that translation. And there's been quite significant debate now of moving the child support grant to be accessible during pregnancy, realizing that the value of the child support grant is certainly significant, but many women only access it quite late. And by doing that, you miss the opportunity to have real impact. So there's debate at the moment to kind of shift the child support grant earlier. In infancy, I think the most immediate impact has been on the Road to Health booklet and the side-by-side campaign. So we've seen significant shifts in that to bring in the new understanding, the nurturing care framework, early child development, the critical value of breastfeeding, and trying to promote exclusive breastfeeding. And so I think all the different, within the field of developmental origins of health and disease, we're starting to see that evidence translate into that applicability through some of those campaigns.
Right. In terms of the study itself, I mean, you've been doing it from Barrow, Krisani Barrow, and this is people who've generally remained for the last 30 years in Soweto. Have there been patterns of behavior amongst the people in terms of moving out, or do you still have that cohort living in Soweto? And how well integrated are they, or how linked are you in the study to their sites of care, primary health care in those settings? Or are they just coming back to sort of your unit and getting care in total? So how does it work?
I think that's a good question. So the Birth to 20 cohort is certainly representative of individuals that have been living in Soweto, the greater Joburg area, for a longer time. So they may not be totally representative of, say, a contemporary community, given influx of migrants into various communities. So these are really long-term residents. And so by default, we have shown that the cohort members certainly migrate, but there's quite a significant circular migration. So they often move within Soweto frequently. Some do move out, but still within the greater Joburg area. The kind of older pattern that earlier studies noted with the migration out, so you would deliver your child in a greater metropolitan area and then migrate back to a more rural community. We don't see that pattern in this cohort. So the more contemporary findings is such that individuals will stay in these urban areas. So that fits with the greater urbanization that we've seen across the country. So certainly movement, but more circular and far less out migration. in terms of their care, they access a variety of sources. And we've tried to understand the health service access better over time. And from traditional healers through to primary health care to even private facilities. So you are seeing for many families a kind of hybrid in terms of managing their healthcare needs, be it for certain conditions, traditional healers, pharmacists, to then other aspects that need more primary health care. So it is interesting to see how those patterns do change and shift, and also change by demographic, particularly in terms of age. But it is a very mixed bag that these families have been accessing over time.
Because some of the question, I think just returning to the point you mentioned, if you sort of took this cohort from 1990, there's been some changes in Soweto where that kind of cohort would have been pretty settled part of Soweto in 1990, I assume. Soweto has changed in the sense that a lot of younger people have moved out. And in its place in the sort of family, in the household, or in the sort of social space, there are a lot of migrants coming in who occupy outbuildings, etc., where the extended family used to. But it's not as large as in Alex, for example. So it's probably a reasonable representation of Soweto, as you've just mentioned. But I wonder about whether the cohort is also representing the way in which, and probably is representing Soweto, because in a way, those who manage to access the hospital barrier or come through, because I think you kind of took them from their birth in the hospital, would that have been altered by the fact that they came through, those are much more assertive type of people, families in a way that are assertive, whereas those who are deferring to the public service would have landed up at the community health center and giving birth there. Do you think there's some of those dynamics that alter the way in which you interpret the study?
Excellent question. So certainly back in 1990, the birth to 20 cohort was very much recruited from birth records. So there were so it was actually from birth notifications. And so that meant you, at the time of recruitment of the cohort, you've got the breadth of babies born in various facilities and not just at Barrow.
Okay, not just, okay.
So I think it was quite representative. So in the time period, so birth to 20 also has another strength is it only took a very small window of 7 weeks. So all births within a 7-week period were enrolled into the cohort. And so we know from birth notifications about 5,000 odd births took place in that period. And we were able to recruit about 3,300 of them into the cohort, with some data on those that we didn't recruit. So I think at the time the code was established, it was a good representation of the more general population born in a variety of settings. However, I think as time goes on, and 30 years in a study, so these children are now adults. For 30 years they've known nothing else outside of being actively involved. So from their birth they've been part of a study, and so for them it's like kind of been very normal. And so I do think there's no way that the cohort could not have had some impact just by being in a study longer term. And obviously, because the variety of data we've collected spans various health issues and the ethics around that, clearly it means that these individuals are more probably aware of health. And so maybe their behavior and access is slightly different. And that's why I think, birth cohorts, long-term birth cohorts are valuable from certain points of view. but in some ways, the ideal world is to keep resampling and having birth cohorts set up. A sister cohort that we collaborate with in Brazil has indeed done that. For every 10 years, for the past 40 years, they've started a new birth cohort.
Right.
So now they have 4 birth cohorts tracking 10 years apart, and they can then look at obviously changes and better look at representativity and generalizability. Yeah. We've not done that obviously in Soweto, but we have various other platforms that are more contemporary. And the exciting development that you may be aware with Shabir and his unit at Barra, they've now set up, for the first time, Soweto as a demographic has a demographic surveillance system in it, which is phenomenal because now you've got over 20,000 households that are going to be monitored longitudinally over time. And so I think we are going to get to granularity on population health better. So yeah, it's quite exciting, not just from our own unit activity, but other sister units, the kind of movement and the development of applying different methods to better get to some of these questions over time.
Oh, thanks. So you mentioned Shabir Mahdi yourself. Which are the other, units at Wits that you think are working quite substantially in primary care, anywhere in Johannesburg? Do you mind mentioning? I'm sure you're familiar with them. Yeah. Which are they, and what sort of work do they do? If you don't mind sharing that.
Certainly. So I think what's really exciting is that there's a strong group of research activity between 3 major units, all housed at Barra, with the majority of the work being in the Soweto area. So there's Shabir Mahdi's unit, obviously very much focused around infectious disease, vaccines. Maternal child health is also a critical area of theirs, particularly around mortality and exposure to infectious disease. Then you have DPHOU, which is more on the non-communicable side of the spectrum. And then you have Neil Martison and Glenda Gray, who leads the pediatric HIV unit. So PHOU has predominantly been in the pediatric HIV space, which they're still very active, but they've also branched out further in TB and other related aspects. So PHRU, DPHRU, and Shabir Mahdi's RMPHRU are the 3 major Wits units. 2 of them also MRC units that are actively working within the space of Soweto and have quite significant links into the primary healthcare network.
Okay. So, and you say you'll do collaborate, broadly in the work you'll do.
Yes, so I think that's also been a good thing, is that we come with different strengths, and so we've joined forces in different ways to share resources and expertise. And when you talk about, be it maternal child health outcomes or other related elements, many of these are complex outcomes, and we need to better understand the complexity, the complex etiology that's driving some of these outcomes. And I think that's why collaboration is so essential, because there's not going to be one person or one team that will be able to fully address these things. And so collaboratively, it's good. Part of the work where we've really synchronized on is, the demographic health and surveillance system that's been set up is phenomenal. That's going to open up a lot of opportunity. And we've been collaborating with Shabir on that. We've also been trying to understand more mechanistic work, the microbiome, and how that changes from preconception and pregnancy and how that may impact various outcomes. And that's a collaborative project. And then with Neil's team and Michelle Ramsey, we are looking at now almost the kind of pharmacokinetics of hypertensive drugs. And that's also in collaboration with public health clinics where we're recruiting hypertensive patients and examining the kind of the drug effects on individuals. And that's a nice collaboration that's just off the ground.
Right. Well, it's interesting. You know, there's also some work happening in the Hillbrow area. Do you know about it? With Helen Rees and the sort of complex around there. Any other units that you know of doing other work in Johannesburg besides the three?
Certainly. So the three of the units I mentioned are predominantly Soweto focused, but you're right. There's a significant amount of other units that are working in other parts of the province and also outside the province. So certainly Helen Rees's Institute in Hillbrow, and there's also the Gauteng Observatory, which is, tries and gets more provincial representative data, is active in the inner city and in other areas. And so those are the two bigger units, but there are several smaller units that are supporting in different ways, be it the more kind of health economic side of things versus trying to deliver interventions through Ian Sanner's unit, and folks that are working at some of the other academic hospitals.
Yeah, I think that's one of the challenges as a district research committee, being in primary care. We get all sorts of applications, and we've been trying to figure out how do we make sense of the terrain? How do we find ways to synergize everyone, get to know who's on board, who's doing what? How would you propose we kind of do that? Get a better sense of who's around working primary care and how we might synergize better. And knowing that the whole of Johannesburg's these sort of grounds that we are responsible for to try and advance the the mandate of the committee.
Exactly. I think that's such an important point. It's an element that, so most of these research units fall within the School of Clinical Medicine at Wits, or related health sciences schools. And the idea is to kind of get to grips more with how these units are operating, where are synergies, and where are unique kind of strengths or differences. And so we've also been trying to get to grips with this ourselves. But the one element that may be useful is something we could suggest to the heads of schools, is that to try and create a forum with the district research committee and some of the research entity directors, just as a more kind of, at least a starting off point to kind of share and give this kind of more global overview. Because I think if, within a couple of hours, if directors shared kind of active work and where they're going, we probably could do a fairly good exercise of mapping out the overlay where these entities are operating across the district or, within the province, and also getting a feel for kind of, where the emphasis is going in terms of their program of work. But yeah, I mean, I think unfortunately it needs more connectivity, more dialogue. But the usefulness of that exercise means that there are potentially really, really good collaborative opportunities that could come out. But also, in terms of the district research committee, creating a better way of how to synergize, support, and also, in a way, input into some of the kind of future plans.
Yeah. No, thank you for that. In fact, just to share with you a little bit of how we think things should move. Well, most of us have an academic background. We know the value of it. We also appreciate that the district and the province has its own needs, and kind of service needs, and how to keep ahead of the curve of, rapidly changing stuff on the ground, the evidence that's being collected in the district, and the political implications. So being sensitive about that, we've been trying to say, how do we actually get ahead of it? Because our specific mandate is to coordinate and manage research processes. And well, that's a very broad process, broad issue. So it's there. We can, in fact, do that. But I think that, we don't have any authority except by being the experts that the district has mandated to help. So we can certainly pull that together. I mean, we've been, historically, I've been part of the research committee, and all they seem to have done is just review research protocols, and not very well, and take ages, about it. And so hopefully we've kind of dealt with that and put it aside. It's happening as fast as we can get it happening, and we'll look to ways to get it happening faster, with picking up problems and getting people to address their issues. But I think that, and even in that way too, what we're trying to do is to just get people to use the NHRD without it being an obstacle. It supposedly is a research coordination tool, but I'm very skeptical about its value in that respect. It's kind of almost administrative, and we'll use it as that. But I think that the two things that we really are concerned about, and in terms of the managing research processes, is to promote the use of health research outcomes, which is actually the last on that, but should be our first one. So we need to take the evidence that is happening actually in the same very district that we're working in, and use it for the district, and we need to make that available to people. So we've tried, we are busy trying to get, after the reviews, to try and get reports from people, and we're busy with that and trying to manage that, although it's a bit secondary right now. And then the second thing that we are trying to do, and I think we can explore much better on that scope. How do we actually do that? And the second thing that we want to do is to mobilize resources for research. And that resources, I think, even though some people have suggested that's resources outside, to me, it's about everywhere, including the district itself. So if the district were to become much more attuned to the needs for research and the importance of research and the alignment to research plans, including experimental type research. And I think that can become very, very important, because often when you're trying experimental research without the sort of ability for district or service managers to buy into it, they're never really happy with trying experiments. And I think that we need that whole synergistic approach. And so I think what you're suggesting as a forum would be a really good way to put this out, spell it out, and see how we can build up a common view that's that's both building up the group, but also getting the district in line. And I think that you can be active partners in helping the district become better aligned to research outcomes. So that Johannesburg, in a way, is a learning organization. Health district becomes like that, and you can be a part of, all be part of that process. So I think that would be really good. So if we were looking at, how do you respond to that little spiel I just went through?
I mean, that's incredibly encouraging. And certainly within the DPHOU space, much of our future planned research, even though there are strands that are more on a population level or quite mechanistic, much of our intervention work can't really ever succeed in terms of what we hope it to be, and in terms of scale up, if it is not in partnership with primary healthcare. And so I think the two examples that you'll hear from Lindsey talking more around gestational diabetes, which, to date is a tertiary hospital monitored, managed component, and where Lindsey's trying to apply novel ways of thinking about it in a primary healthcare setting, which is, I think, really where it should be. Is some example whereby we are trying to translate outside of just tertiary centers into primary healthcare and see what works, what's manageable, etc. And Lisa and Letu's example, whereby one can start thinking of partnerships in a very novel way. And the Health Hub partnership that they'll be presenting on brings in a fascinating model of public healthcare collaboration with private, with other partners, to how can we have greater impact in the community broadly. Health is obviously important, but how could we have a broader impact? And the Health Hub model, I think, is a really innovative way of how we can be in a community and partner with primary healthcare and such. So for us, I think that is the way to go. So it's very, very encouraging to hear, firstly, how to get greater buy-in to research. And I think through better engagement, we'll get that buy-in from clinic managers and other stakeholders. And then also how to really apply the findings. You know, it's one thing to do the research, but then how to think about how that works in improving, obviously, the health of the populations that we are investigating through our partnerships. So yeah, from my side, that speaks exactly to partly where we are doing more and more work in, and certainly aspire to have that effect.
Yeah. Well, it's great. I mean, one of the things that I'm busy trying to put together is just a small assessment of the research agenda amongst managers. And we really need to engage with them. So we've put our, our emphasis as well in trying to do this now. How do we get the managers actually sharing with us their agenda? What do they want happening in research in the district? Because there's many times they've complained and it's kind of been there, but often very poorly thought out. Well, we don't like the fact that people are researching certain things and that those are sort of not integrated to what we think need to be addressed. Well, hang on, have we actually got that clear what our research agenda is instead of a generic list of every condition? What exactly do we want researched? I think that if we can get them to say it clearly enough, then we can get that kind of collaboration better structured. The other is that, people on the ground, again, clinic managers and the like, senior managers, are not clear about, they think of research, if they're not studied, and even though they have studied, they think of this really difficult thing that they have to do, and it's just hard, and it's there for people who are too clever for themselves, and just come here and take what they want and go away. And I think that's the kind of name that researchers have in the district. It's seen as almost opportunistic and exploitative. So I think that we need to change that mentality, partly to get them to see what research is. It's not as sort of demystified, but also to get them to realize that, well, hang on, you can do it, small stuff around you, and we want to try and link it. And we hope that we can get, from this forum, people who will help us to be part of that process, including then saying, now that's a key problem that I think that comes out. And in fact, at some point, there was one research chair in the DRC that said, we want to know where your money comes from and tell us what it is. That became quite a sore point for lots of people. The truth is they were collecting information. People were giving them all sorts of very bland stuff and never really got taken up. But I suspect that it came from a point of view in the district as well. These guys walk about, with lots of money in hands, and they're never really using it to help us. So I think there's this tension. But I think that forum you've just talked about, Shane, would be a useful. I think that's exactly what Prof Shabir Mahdi also raised, and I think being the dean, he'd probably be in the best position to take it up with your help and others, for us to look at how we can find a way to collaborate and to build much more ways that we can make it really happen, better research, better outcomes, and impact on the service in the community.
And I think also it would be super helpful for us if we could also hear some of the needs from the district, partly in terms of where there may be opportunities for capacity development, but also what they may perceive as research priorities. Again, because I think everyone has a unique point of view from where they are sitting. And if we could get that perspective, that would really help us better, think about how we could tailor our research to address and include those perspectives. I mean, the encouraging thing is that certainly COVID has had a significant impact on multiple levels. Economically, financially, I think the country is going to live with the aftermath for some time. And this is not just here, it's global. But what I am so encouraged about is that despite such difficulties, global health funding, the prioritization of global health funding has not wavered. In fact, I see it intensified, such that the opportunities to fund global health relevant research is probably more now than I've ever seen before. And so there are really opportunities to harness those type of research funds that speak directly to on the ground level effects and work. So this is work that really does need to happen in primary healthcare settings. But I think to be more competitive and to have greater impact, we need these different perspectives. So that's also maybe another possibility is, and certainly maybe a take-home message for me in my own thinking in the unit as we start tackling some of these grant opportunities, is maybe we should also be thinking of bringing in partners from the beginning. So if we are thinking about Project X for a global health grant, maybe it should be having a conversation with yourself or other members or other folks in the clinics and bring on board folk as part of the team right from the beginning. So they're part of the research idea thinking. They can then potentially look at understanding that, but also create that ownership. And then we can get their points of view early as opposed to after the fact. So there may be some unique ways we can think about drawing these various groups closer together collaboratively.
Great. I think that's the way to go. And I think building ownership, widely, especially, in the district will be a very important task. So we'll talk more about that. Thank you very much, Shane, for taking your time out to share your thoughts. And I hope we can take this collaborative approach forward. And I'm sure we will. And Shane, if you need to drop off, no problem. I understand you're on leave, so time is precious. But thank you very much once again for coming and sharing your thoughts. We'll go to the next person who's going to talk about the work of the DPHRU. And I want to introduce Dr. Lindsey Dixon. She's a physician working on diabetes in the MRC and DPHRU. And she's going to talk about detecting and preventing gestational diabetes in a primary care setting. Shane just mentioned her work as quite important in the response by locating things at a district health service level. So Lindsey, thank you very much for joining us. I'm sure you can unmute, and I hope you can share. If you don't, let me know. And if you don't mind just introducing yourself, I was far too brief in talking about you. So please, if you don't mind sharing a bit about yourself.
Okay, and I think that covers most of it. So I'm a physician in private practice, actually. So clinician, not an academic, not a researcher. Fell into a PhD by accident, and Shane was kind enough to give me support with that whole process. So the whole project is diabetes, but my clinics are diabetes based. And particularly gestational diabetes, because I really think that if you can find a way to get to the problem at the very beginning, maybe we're not going to end up with the total body crumble we see in our adult clinics, or something close to it. So I'm going to give a presentation on our study results. I'm going to share screen now. Is that okay?
Yes, go for it. And I'll mute myself while you talk, and we'll come to some questions. So please feel free to put into the Q&A any questions. If you have any for Shane while he's around, we'll ask him, but please use the Q&A to put things out there. And thank you, Lindsey. Over to you. If you're able to share, are you able to manage the share?
It's not really going there now. Share, open system preferences. Nope.
If you click on the green screen, share screen, but if you haven't opened up your presentation, it might not show.
As a presentation is open.
Yeah, then if you open up the share screen, then you'll see something which is your PowerPoint, and then you can just click on it. It should be good to go.
It's not going at all.
What I suggest to do is just close the share and just open it again, or reopen the document, and then you probably will pick it up on share screen once you open that again.
Oh. Open system preferences. Why is it opening system preferences?
You've got the whole bundle of different screens in front of you.
Mm-hmm.
Shall we move to Lisa and then give you a bit of a chance to figure that out? Does that sound all right?
I appreciate it.
Good. Don't put you under pressure. Lisa, I'm not sure whether you are okay with presenting while Lindsey gets herself organized with the share screen.
Thank you, Jhb. I'm happy to step in if it's helpful, although it looks as though we might be having some progress.
Yeah. Oh, you mean Lindsey's got a screen up?
Got a screen up.
Ah, all right. Lindsey, fine. You've got your screen up, so you can just put it on. Yep, that's it. Good. Go for it, Lindsey. Sorry,
you can
Lisa.
see my screen.
Yes, we can. Thank you very much.
Thank you.
All right.
So the study was concerned with gestational diabetes in an urban community health clinic. We were based in Zola Community Health Clinic. As Shane has already mentioned, at the moment in South Africa, gestational diabetes screening and treatment are hospital-based practices rather than primary health or community-based practices. So the purpose of our study was to investigate the feasibility of a universal gestational diabetes screening program within the usual functioning of the community health clinic. And we were going to use inexpensive, ordinary handheld glucometers as an alternative to the laboratory to measure the glucose in the oral glucose tolerance test. So just a little bit of background, gestational diabetes, it was previously identified as any level of hypoglycemia first detected during pregnancy. And this was the American Diabetes Association definition. And it was very appealing because it had absolutely no diagnostic thresholds attached to it. And then in 2013, World Health Organization separated this into two distinct clinical entities. One was a diabetes in pregnancy, which was an overt diabetes, and probably equivalent to a preconception diabetes. And then the second was a gestational diabetes, an intermediate hypoglycemia. This decision was based on the results of the hypoglycemia and adverse pregnancy outcome study, which was published in 2008, as well as by the International Association of Diabetes in Pregnancy Study Group, and their consensus statement came out in 2010. In 2016, World Health Organization estimated that 16% of pregnancies globally are affected by gestational diabetes. So it is an asymptomatic condition. And so if you don't screen for it, you're not going to find it. And it's usually transient. So it starts at middle of second trimester, beginning of third trimester. And the moment the placenta is birthed, it actually resolves. It is associated with poor antenatal outcomes as well as poor perinatal outcomes, the most common of which are preeclampsia, macrosomia, when you birth a 4.5 kilogram baby and above, as well as a need for cesarean birth. There's an intergenerational transfer of diabetes risk, and so the risk of type 2 diabetes is transferred to the child. Gestational diabetes is a diabetes precursor and is equivalent to impaired glucose tolerance. And 50% of these women will develop overt diabetes within 10 years. And so it's important because in South Africa, we have diabetes as the second leading cause of death. HIV is number 5. We do not yet have a diabetes prevention program, although that science has proven to be economically active and effective since the last century. And we do not yet have a strategy to identify high-risk individuals who would benefit from a diabetes prevention program. Okay. So in terms of screening tests for gestational diabetes, the diagnostic test is the oral glucose tolerance test. Women are given a 75-gram oral glucose load. This should be done at 24 to 28 weeks gestation. The test is laboratory dependent, and this by itself means there's going to be delays in diagnosis and delays in treatment. The WHO 2013 diagnostic criteria for overt diabetes, it's the same as that in the non-pregnant adult population. But for gestational diabetes, only one abnormality is necessary for a diagnosis. So any pregnant woman who's got a fasting plasma glucose that's greater than 5.1 is diagnosed as having gestational diabetes. At 1 hour of the oral glucose tolerance test, it's greater than 10, and at 2 hours, it's greater than 8.5 millimoles per liter. The WHO in 2013 and our local center in 2017 acknowledged that universal screening for gestational diabetes is advocated and appropriate, but both of these organizations acknowledge that the cost of screening is going to be a limitation to a rollout. Our current policy is risk factor-based selective screening, which is in the South African Department of Health Maternity Guidelines of 2015, where women are asked a series of questions, and if they're found to have a risk factor present, they're referred to the hospital for an oral glucose tolerance test and further evaluation. There's delays and missed opportunities inherent in that process. But despite that, if they get to the oral glucose tolerance test, still more than 50% of GDM cases will be missed. Okay. I'm going to present our study results in 4 different phases. The first is an evaluation of the effectiveness of our current selective risk factor-based screening versus a universally applied fasting plasma glucose to screen for GDM. The justification for this is in the HAPO study of 2008, more than 70% of women who were diagnosed as having gestational diabetes were diagnosed based on an elevated fasting plasma glucose. But this did vary between countries, between ethnicities. And then also the International Association of Diabetes and Pregnancy Study Group have observed that there's a low probability of GDM and a low probability of adverse outcomes if the fasting plasma glucose is less than 4.5. And so a dual threshold has been proposed in low resource settings, where a universally applied fasting plasma glucose of less than 4.5 excludes GDM, and a universal fasting plasma greater than 5.1 is diagnostic GDM. And then the second part I'm going to present is an evaluation of the reproducibility of gestational diabetes diagnoses using different laboratory methods to measure glucose in the oral glucose tolerance test. There have been recent reports coming through from England, from Europe, where there's differences between routine laboratory service and research laboratory service in terms of gestational diabetes prevalence estimates. And then I'm going to also give a little bit of information on the validation of plasma calibrated glucometers for the diagnosis of gestational diabetes. The use of plasma calibrated glucometers for diagnostic purposes, because they're normally used for self-monitoring of blood glucose in existing diabetics. Their use for diagnostic purpose in low resource settings is advocated by the Federation of International Gynecologists and Obstetricians, as well as by the World Health Organization. And then lastly, we're going to document personal experiences of urban African women affected by gestational diabetes, because we don't have any local qualitative data. Okay. Our participant recruitment. We were based in the antenatal clinic of Zola. We approached 1,270 consecutive women for screening. This was between April 2016 and May 2017. Of those we approached, 969 were eligible and willing to participate. And those criteria were they needed to be 18 years or older, they had to be less than 29 weeks pregnant, and they could not have had preconception diabetes. Historically, there's about 1,000 women per year who give birth at Zola. So I think we managed to approach most of the women who attended that antenatal clinic for first visits. Of the women who were recruited but did not have an oral glucose tolerance test, it's about 303 of them. The three most common reasons why they did not proceed to glucose tolerance test. 95 of them defaulted their appointment despite confirmation. We lost contact with 58 women. There's another 50 who had a miscarriage before they could have the glucose tolerance test. And then there's an additional 100 women with various other reasons. They were admitted to hospital, they were having exams on the day, they had a glucose tolerance test at the academic hospital. There were another 74 women where they had the glucose tolerance test, but we excluded the data from analysis. 14 of these women did not have a complete glucose tolerance test. Either they vomited out the incredibly sweet liquid they had to drink, or we were unable to have venous access to complete the venous punctures. And this was particularly in our more obese patients. And then in the initial phase, we only used one reference laboratory as a calibration exercise of the glucometers. Subsequently, after this first initial phase, we actually used two different laboratories as a calibration exercise for the glucometers. And so finally, we had 592 patients where we had a complete data set which was submitted for analysis. Our study methods, participants arrived fasting. They were given a 75-gram oral glucose load. At 0, 60, and 120 minutes, they had a finger prick with a capillary blood glucose measured by the glucometer. Results were available in 5 seconds, and participants were informed of the results on the day of testing. Within 5 minutes of the finger prick, they also had a venous puncture where plasma glucose was measured at 0, 60, and 120 minutes. Blood was collected in the grey top tubes, which contain the glycolytic inhibitor sodium fluoride. Samples were transported to the laboratory on ice at the end of the OGTT. 2 laboratories were used. The one used a hexokinase method to measure glucose concentrations, and the other used a glucose oxidase method to measure glucose concentrations. Participants were informed of these results a week later. Laboratory results were considered true. Positive glucometer and negative laboratory was considered a false test. Our results on GDM prevalence, overt diabetes in pregnancy, was detected in 3 of our participants, that's 0.5%, and the same 3 women were identified by all methods of measurement. That's the glucometers as well as both laboratories. Our GDM prevalence, or the intermediate hyperglycemia, it was positive in 95 participants by all methods, which is 16% of our study population. There were 95 participants, or 12.7%, were positive on glucometer, and 53 participants, or 9%, were positive on the laboratory test. It's a composite laboratory test with the glucose oxidase and the hexokinase methods. So things unravel at that point. The Zola GDM prevalence was 16%. Our global GDM prevalence was 16%. But the truth becomes increasingly messy. So our glucometers had 42 unique GDM positives not identified by the laboratory. The glucose oxidase had 17 positives not identified by the hexokinase method. And the hexokinase method had 2 tests that were unique as well. Come back to that just now. Our participant characteristics, I've listed the South African National Guideline characteristics there, but in our study population, the mean body mass index was 26.9. So in general, they were overweight. Their mean age was 27.8 years. 16.8% had a positive family history. 29.2% were pregnant for the first time. 0.5% had previous gestational diabetes, 7.3% had previous large for gestation age fetus, and all of our patients were urban African women, in keeping with the clinic patient profile. Our participants' characteristics strongly associated with the GDM positive characteristic. There were only 3: maternal age greater than 40, body mass index greater than 35, and a later presentation for their first antenatal visit, which I still don't have an explanation for. In terms of the effectiveness of risk factor-based screening versus universal fasting plasma glucose, this is published data. For this paper, the GOX method, the glucose oxidase method, was used as the reference test, and World Health Organization 2013 diagnostic criteria were applied. Based on the presence of more than one risk factor, so selective screening, 204 of the participants were positive and would need to have been referred to the hospital for an oral glucose tolerance test. So that's 34.6% of the clinic. Of those who would have been referred, it still would have missed 18 of the 41 laboratory positive diagnoses. If a universal fasting plasma glucose of 4.5 was applied, only 150 participants would need an oral glucose tolerance test, but 2.4% of positive diagnoses would have been missed. In this study population, the fasting plasma glucose of 5.1 is diagnostic, and 87.8% of the glucose oxidase laboratory diagnoses were positive based on an elevated fasting. A fasting glucose of 5.1 would have missed 12.2% of diagnoses in that space between 4.5 and 5.1. So the dual threshold was applied with the 4.5 and 5.1 cutoffs used. 19.6% of patients would have needed a full glucose tolerance test, and 2.4% of diagnoses would have been missed. The laboratories. The laboratories had poor correlation, but let me just break it down slowly. The mean plasma glucose concentrations at 0, 60, and 120 minutes of the glucose tolerance test for the glucose oxidase laboratory was 4.01, 5.42, and 5.12. For the hexokinase laboratory, this was 4.13, 5.62, and 5.27. So at each time point of the oral glucose tolerance test, the HK laboratory had a higher mean glucose concentration than the GOX laboratory. The GDM prevalence did not reflect this. So the GOX laboratory had a 6.9% prevalence despite the lower mean glucose, and the HK laboratory had a 5.1% GDM prevalence. And the reasons for this discrepancy were partially explained by 2 factors. The one was we did a Blount-Altman method analysis. We paired blood samples from the GOX and the HK. The difference between the pairs was plotted on a graph, and the HK method was found to have a consistent negative bias of 0.2 millimoles. So the mean was higher, but the paired results, it was consistently lower than the GOX. Also, the interquartile range for 1,766 observations. The GOX method, the interquartile range was 1.7, and for the HK method, it was 1.55. So if you had to picture a bell-shaped curve, the GOX method has fatter tails than the HK method does. And so the glucose oxidase method had, the distribution was more platykurtic. Only 34% positive GDM diagnoses were common to both laboratories. And so only 18 of the 53 laboratory confirmed diagnoses were common to both laboratories. So it's possible that the hexokinase and the glucose oxidase methods to determine GDM prevalence may not be directly comparable. They're not equivalent. And this becomes a problem because it's the glucose oxidase method that was used in the hyperglycemia and adverse pregnancy outcome study. And this study was the major data that informed the WHO 2013 diagnostic thresholds. This is a massive study, more than 23,000 patients in 15 centers across 9 countries. The study is not going to be repeated. And the additional problem is that hexokinase might have underestimated gestational diabetes, but the hexokinase method is used by our national health laboratories, by AMPATH laboratories, as well as by Lancet. Okay. In terms of the glucometers, we attempted to validate 5 commonly used ISO 2013 compliant plasma calibrated glucometers. I've listed the ISO 15197-2013 minimum systems accuracy recommendations and these glycemic targets. We also had to test at least 100 participants per meter with 3 different test strips, lots, 10 glucometers per band over a 10-day period with 100 paired results, with capillary and venous specimens drawn 5 minutes apart. And after going through all of that, only 3 of our glucometer brands evaluated fulfilled ISO analytic accuracy requirements. And this was only achieved at fasting. So it's coincidental and fortunate that 80% of our participants were positive based on an elevated fasting glucose. The overall glucometer results for all of the glucometers fulfilling ISO analytic accuracy recommendations at fasting was 92.4% of measures. At 1 hour, it was 49.8% of measures. And at 120 minutes, it was 61.5% of glucose measures, respectively. On the Blount-Albert method with the paired difference, the difference was minimal at fasting at a 0.22, significant bias of 0.96 at 60 minutes and 0.73 at 120 minutes, with the glucometers being consistently higher than the laboratory test. Glucometers did not perform equally well, so the Contour Plus and the Freestyle Optium Neo brands performed well against both of the reference laboratories. But the GlucoCheck and the One Touch Select Plus were associated with a large number of false positives. In fact, 54.2% of all glucometer false positives were with the GlucoCheck classic meter. The EchoCheck active meter had other problems. The device performed really well against both laboratories, but the glucometer was visibly easily soiled with blood and so considered it to be a biohazard. All of the other glucometers we actually cleaned and reused on another day. With the EchoCheck active meter, because I really did consider it to be a biohazard, it was used once and then the entire device was disposed of. And so fewer participants were tested with this meter. We didn't get to 100, I think we did 54. And these glucometers are intended for single person use. Because this one is very easily contaminated, it might not be suitable for multiple person use. The EchoCheck and One Touch glucometers missed 1 and 2 GDM diagnoses respectively against the glucose oxidase laboratory. It's gonna go. I just want you to look at the sensitivity and specificity on this slide. So on the one axis, I've got the statistical observations. On the x-axis, I've got the different glucometer brands. This is the published data with hexokinase laboratory as the reference test. And both the sensitivity and the specificity perform really well for two of the 5 glucometers tested, okay? When you look at the composite laboratory test, the sensitivity drops off spectacularly. So the mean sensitivity is 62% and the specificity 92% for all glucometers. But so for all glucometers, that's the result. And then the individual glucometers performed at different levels. Still, it's the Contour Plus and the Freestyle that had the best overall results. The EchoCheck, we tested few participants and they missed one of the positive diagnoses, and so the sensitivity was negatively affected with that. The GlucoCheck and the One Touch Select both had a lot of false positive diagnoses as well as misdiagnoses, and so they performed badly. All this actually means is that the glucometers are very good at ruling out GDM. Okay. This is information in a different platform. This is the mean blood glucose concentration for the, this is a hexokinase laboratory results. And then here are the 5 glucometer brands. The outlier, this one is actually the GlucoCheck Classic, which was way above the other glucometers in terms of accuracy. It reported significantly higher measures compared to the laboratory than the other glucometers did. There is some other information I need to give to make this interpretation even more difficult than what it already is. We know that in a routine clinical setting, with a 60-minute delay in processing of glucose samples, there will be a 14% less GDM positive diagnoses detected. And part of that reason is because we know that blood glucose concentration drops by 5 to 7% per hour due to ongoing glycolysis in this gray top tube, because the sodium fluoride is not a particularly good stabilizer, particularly in the first 4 hours. So in summary, for the quantitative component of the study, glucose is not an easy, a simple molecule to measure, that a universal fasting plasma glucose required less women undergo an oral glucose tolerance test with fewer misdiagnoses, that a dual threshold would further reduce the number of women requiring a glucose tolerance test, and that there was a clinically significant bias between the glucose oxidase and hexokinase methods, and the results are not truly interchangeable or directly comparable. Hexokinase may have underdiagnosed gestational diabetes. Selected glucometers may be suitable, but only to evaluate a fasting plasma glucose, and glucometers missed fewer diagnoses than either laboratory. Just in terms of meaning and purpose of the whole screening process, all methods of measurement identified participants with overt diabetes, and typically these patients would require insulin therapy and would need to be referred to hospital because they have significantly higher risk of stillbirth and other complications. The Gtm interventions, there were none, it's not recognized as a distinct clinical entity in South Africa. And so we offered women the service at Zola Clinic. And our, in general and in our sample, more than 70% of patients were treated with simple education and monitoring and nothing else. Do I still have time?
A few minutes, if you can just quickly go through this.
Okay, so this is the experiences of women who actually had the gestational diabetes. We interviewed 10 women, focus group discussions that were recorded, transcribed, and analyzed. And some of the results were that when the women who were diagnosed as having diabetes, they had the shock and fear because they lost it no longer had a normal pregnancy. Those who had family support, particularly if a family member had diabetes, did better, and sharing the experiences with their peers while they were waiting in queues did give them some relief from anxiety. They were aware of inconsistent implementation of GDM diagnostic procedures at tertiary versus community health clinic, and this did add to their confusion. They had difficulty adjusting to the diet. They described it as unpalatable, cardboard soaked in water. But when they did manage to adopt these, they considered it a positive consequence of their diagnosis. Some of the healthy lifestyle changes were maintained postpartum, and it's supposed to have had a positive effect on other family members. The women had little awareness of their long-term risk of developing diabetes. They had no idea where to go for regular screening. And unexpected finding in the study is that the majority of participants agreed that they would rather be tested HIV positive because it would be less stressful than living with diabetes. So in conclusion, the participants considered being HIV positive as preferable to having GDM. And this may reflect their distress caused by inadequate pre-test counseling, inconsistent health information, inconsistent screening practices, and suboptimal support from healthcare professionals. Done.
Thank you very much,
Thanks.
Lindsey. Appreciate that. Is that your PhD? So well done.
Yeah.
Good. I don't see any questions, but perhaps I can just ask you to put it in very simple language. How would you as a practitioner, you're a GP, now be able to say, I'm doing things differently? what is the difference you're doing in practice? Having using your knowledge gains here.
So I have a large diabetes clinic, two large diabetes clinics that we're actually running. And the patients who come here are existing patients who are known to be diabetic. We are getting more referrals in from gynecologists who actually are screening for gestational diabetes. But there's been very, very little uptake, despite the fact that I've individually approached them to please increase their screening.
Right.
And so the PhD started off when I had, within a space of 1 month, I had 3 patients walking off the street who were not known to us. And all 3 of them had had a stillbirth. And the comment that they got from the doctor, it was, oh, maybe it's because you had diabetes. And they were not aware that they had diabetes. And so there was that kind of experience that got me started on this study in the first place. We don't have a change in national policy, and without a change in national policy, we're not really going to be able to improve outcomes. The study is supposed to have made testing less expensive. A laboratory glucose tolerance test is close to 200 Rand, whereas a glucometer glucose tolerance test is about 20 Rand, and it missed fewer diagnoses. So in theory, it brings the cost down substantially. There's no way that 1/3 of Zola's antenatal clinic would have been sent through to hospital to actually have a glucose tolerance test done because they were high risk. So even if the risk factor screening method was applied, it would not have been implemented because 1/3 of the women would not have made it in time.
Yeah. So your bottom line would be screen patients early in their pregnancy, screen women early in their pregnancy, and use the threshold which you had suggested, which is 4.5, and try to use these 2, Contour Plus and Freestyle, as the better of the quality of glucometers. And you're probably better off. Thank you very much. Really appreciate your time and wonderful work. Thank you very much. Let's move to Lisa. Lisa, do you feel okay to share and continue? And if you can just introduce yourself briefly more than I have. Lisa is basically a senior researcher at the DSI NRF Center of Human Excellence, Excellent Human Development, and 20 years in managing chronic disease in the prevention and management through behavior. So also she's got with her Mr. Letu Kopweja, and they're going to talk about the Vits Health Hub, training center for Soweto youth, and the interface between community and primary health care clinics. Thanks, Lisa. I'm sure you can share, and then if you can just introduce Letu if he's going to contribute as well.
Thank you, Shabir. So
great.
Let's see if I can.
Yep.
Great. Okay. So I'll introduce my colleague Letu. So he was also at the Centre of Excellence for Human Development, and he is now busy with a master's in public governance. So I'm sure he can tell you a little bit more about that. But we've been working on the Health Hub program now, designing the program and trying to bring it into implementation for probably around 2.5 years. So the program sits within the DSI NRF Centre of Excellence, but we collaborate and work very closely with the DPHRU. So this afternoon, I'd like to just give a bit of background to the Health Hub idea and to explain what the Health Hub actually is and where we're currently at with the pilot study. Then to talk a little bit about where we hope to go, and then hand over to Letu to talk about the importance of community engagement in the whole process. So you've heard Shane talk about DPHRU and the Birth to 20 study, and how in 1990 there were 3,000 mums and babies recruited, and today we still have many more, many of those families with us, and now with 3 generations in that cohort. And some of the key findings, which you've already heard this afternoon from this, really point to the fact that the risk for future ill health is intergenerational, and we can see this already in children. So, for example, here's one of the Birth to 20 publications showing that fracture risk in adolescence is related to maternal bone mass. Here is another study that Shane also talked to a little bit earlier, showing how low birth weight and accelerated growth in early childhood increase risk for diabetes in adulthood. And these were findings from Birth to 20, but these were also reinforced from cohort studies in 4 other low middle income countries. So this really begs the question around, when is this transmission of risk, and then when do we intervene? Because this would suggest that it's during or even before pregnancy. So in a couple of years ago, Shane was very involved in setting up the Healthy Life Trajectories initiative. So this is a big study which is operating in India, China, Canada, and in South Africa, and is supported by the World Health Organization. So in Soweto, where the South Africa arm sits, there's a randomized controlled trial to recruit around 6,000 young women between 18 and 28 years of age, ideally before they get pregnant, and then to evaluate their health and to support them to improve their health, with the overall aim to see, does this then impact the child at age 5, and hopefully we can continue the cohort to later in childhood. And the primary outcome of the study is really to try and impact child obesity. In the intervention arm of this study, the young women work with health helpers. So they receive one-on-one support to make healthier choices. They use a technique called healthy conversation skills, which is also used in the UK within the National Health Service. And the aim, as I've said, is to screen and to optimize health, including mental health, to improve nutritional status, including micronutrient supplements, and really begin to build a strong foundation for early childhood development. And the trial is going well. I think there's maybe around 1,500 or so young women in to the trial already. But the reality is that young people that don't have employment and education really have very limited choices around health and health behaviours. And some of the work that we did to support the development of the intervention for Healthy really showed us that young people are struggling to afford food and to access food. So that, consistently the message was that the foods that are on their doorstep are cheap and generally unhealthy. Also, that if there was no financial gain from doing something, then frequently they would look at perhaps doing something else. So we know that to improve health, we also have to recognise the constraints in which these young adults in Soweto live. And pre-COVID, we know that around half were unemployed, over half were unemployed, and over half are undereducated. And this is, of course, related to mental health, and we're seeing this in terms of increased risk of depression in these young adults. So the idea was born for the Vits Health Hub, and the Vits Health Hub is really a training and research platform. So we recruit young people who are not in education, employment or training, often referred to as NEET. They receive a stipend, a monthly stipend, while they're with us for the 12 months. They also receive NQF Level 3 training as a health promotion officer, which is part of the community health worker spectrum. We provide training in how to do research. We provide workplace experience, which is something that's very critical for these young people that have never had a job and can't say that on their CV. And we also give quite intensive career guidance and psychosocial support. So this is for the youth, but we're also hoping to have an impact on the community, because the trainees, when they're under supervision, conduct home health checks for the most frequently observed chronic conditions. And they, as part of their training program, deliver a number of community health awareness events. So the first one will be in January, probably around the Jabulani area, really focused on hypertension. Our real aim for this is that these trainees, through taking this program and going on to work in health, and this is what we're hoping, become real role models for health within their communities and within their households. And also because they adopt a healthier lifestyle for themselves, they impact the health of the next generations. So you can see here is a bit of a write-up for one of the people in our program. And the sources of income, this source of income is critical in the households that these young people live in. And you can see some of the struggles that they're having to find work. So we have young people that want to go on and do occupational health and safety, young people that want to get into nursing, young people that really are dedicated to health and want to stay in the health space. So where we are now is we are just about to start the pilot study. So the first cohort of 20 young people started with us in October. We're waiting our final Vits HREC approval to evaluate the impact of the program, specifically on the health and welfare of the young people. So once that comes, and hopefully any day, we'll collect data on the fitness and health of these young people, including mental health, stress, resilience to stress, and a whole range of physical assessments, health behaviours, socioeconomic status, and quality of life. All of these measures will be repeated at 6 and 12 months to see what is the quantitative impact of the programme on these young people. And we'll also conduct interviews and focus groups with the young people, but also others involved with the programme to see what is the qualitative impact of this pilot study. So our plan is to take another 20 young people starting in October next year. At the moment, the young people are operating out of the Barra. They're doing face-to-face training with our partner in this, who are Kunakanya Training Academy. And in March, we are moving to the Jabulani Sports Complex, which should be ready to occupy, hopefully in March, with our partners, including Safe Hub and Amandla. Safe Hub and Amandla use football to engage young people from the age of 5 into after-school programs, and then to access a broader range of services and facilities. Another partner is R Labs, who deliver training on various IT and digital solutions. And the whole program is really supported and funded by the City of Joburg Sports and Recreation and the Development Bank of South Africa. And you can see the site here. It's a phenomenal site. There's a cafe for young people, there's a digital library, the football field, there's basketball fields, there's 2 swimming pools. It really is an amazing site in the heart of Jabulani. And the site really represents a one-stop shop for young people. So the idea is that a young person comes and registers at the centre and can sign up for a number of training programmes, for a number of opportunities, can be helped to find education opportunities or employment opportunities. And this really speaks quite strongly to the basic package of support model that's being developed currently through the Office of the Presidency. So where we hope to go in 5 years is to build much stronger collaborations with the clinics, primary healthcare, and to work with the ward-based outreach teams to integrate our young people. Part of their training program is that they need to spend time in clinics and with the ward-based outreach teams. And we're starting these conversations now to organise that. And we're hoping that through this, we can extend and expand the reach of the clinics into the community. We're working already to evaluate the impact of this programme on the learners themselves, but we want to extend that to see what is the impact on their families, their households, and on the wider community. And critically, it's about creating a research and data collection platform. So the learners are trained on top of their health promotion skills in how to collect data, how to use REDCap, for example, to collect and store data, on research ethics, on a range of different skills that perhaps are not typically delivered within that community health worker type training. Each of the cohorts of 20 trainees, when they're with us, can visit around 3,500 households during the training program. So the capacity to collect data is actually quite large, and we're actively seeking collaborations to embed research studies and postgraduate students within the program. So the interaction with primary healthcare and with the District Research Committee at the moment is really around training, working together to support the training of these young people, but we want to look for opportunities to expand that into how can we collaborate better in research in this space. And then over the next 5 years, we're hoping to train between 100 and 500 health advocates. 500 is our aim, through this 12-month program to become these health role models for their families, households and communities. And through conducting these supervised home visits in training and delivering health promotion, we're really hoping in 5 years that we can reach the whole of Soweto, so every household, including the informal settlements, through this program, to improve diagnosis and treatment rates of conditions, particularly asymptomatic conditions such as hypertension, to improve health literacy through working with the community within their households, and signposting and helping people navigate the health service infrastructure within Soweto and accessing referrals to the services that they need. So at this point, I'll hand over to my colleague Letu to talk about the importance of community engagement in the programme.
Thanks, Lisa. Letu, go for it.
Greetings, everyone. I hope you can see my slide. I just put it up just now.
Yes, thanks, we can.
Great, thanks, Prof. So yeah, as Lisa mentioned, my name is Letu Kapweya, and I'm working with her and another colleague in the Vits Health Hub project. I mainly look after the partnership side of things. And, you know, a project like this, Lisa's already started describing some of the partners that we have. And she mentioned those that are more on the site or the complex operational level. But a project like this has a variety of partners, interest groups, so people who are just generally curious about what we do and want to see opportunities to work with us. And so there's a lot of partnerships and relationship building that comes with this. By profession, I'm a research manager, and I've been working for the Center of Excellence in Human Development until 2020. And I'm also studying, and my studies are really focused on youth development, and especially around how we can pull together a variety of partners to make youth development work better. And so that's a bit about me. So the Health Hub project itself sort of comes into operation really this year. And after a variety of engagements with many partners, especially on the operational level. And so that will be your DBSA, Amandla Safe Hub, and our labs, and others really that we were engaging to see how we can make this a reality in the Jabulani community. But of course, the intervention itself is very localized. And by that, I really mean our pilot is focused in Jabulani. And as a result, we have to work within the kind of wards that are located in and around Jabulani, which we call our catchment area. And so these wards have been given to us because of the nature of where we are located or where we are going to be located. I mean, at this point, we are operating out of the Barra, but once our learners and really most of our operation moves into the Jabulani Sports Complex, that's going to be our localized operational area. And so because of that, we want to really see how we can start building partnerships in and around that. Now, the word on the street, so to speak, is Jabulani is being called Sandton in Soweto. And that's really just reflecting on the way that the local community feels that there's a level of development in Jabulani that puts it to, an environment, a living environment like your centers. So there's a lot of sort of good feeling around what's going on in Jabulani, and we really want to leverage on this energy so that we can also start to bring in this issue of better health and living a better life and health and wellness, so that people can start to enjoy, the area they're living in, because they're also, living healthier lives. And so we are working with a variety of partners that, by virtue of us being linked to this precinct or this complex by DBSA, we've been introduced to some of the partners that already have relationships on the ground. And through those relationships, we're able to start doing our community engagement work. And so, the Jabulani Sports Complex itself has very strong relationships with the City of Johannesburg Sports and Recreation Department. And that's really because there's a very strong sports and wellness strong programs that are going to be running in the complex. And also we know that the city of Joburg is the one that really put up the building, and so they're going to be maintaining the building and they're going to be running some of the programs there. And so sports and recreation have been really instrumental on getting us really linked to the government community engagement work that we are trying to do, because they have links to, for instance, the regional director's office that has a database and links to a variety of organizations that are working in and around Jabulani. And that helps because already we get a sense that we don't have to go and reinvent the wheel, creating our own lists and people that we're going to contact, but there are already people that they are in touch with. However, we're cognizant of the fact that not every youth group and not every health NGO or CBO or even faith-based organization doing some work in health is organized or formalized, so to speak. And so we are also looking to working closer with those sort of unorganized groups that are in and around Jabulani. And it has helped for us to run these workshops because we're beginning to discover them and importantly start engaging them on how they think they could really add value and we add value to their work. So it forms a kind of relationship that, there is mutual benefit. And I think we also want to have a group of people that are going to help us walk this road of entrenching a project like ours in the local community in such a way that the local community also has ownership over the project. And this is important for us because this group of people, we loosely call them a community stakeholder group, is also going to be our eyes and ears on the ground on really what are the health issues that we need to be focusing on in order for us to be able to create relevance for ourselves in this particular local community. And this is important for the pilot so that already we get community buy-in from the onset, and we can start defining with the local community what really is the health issues that need to be tackled. And when our health advocates go into the local community, they also have a sense of what really are the health issues that need to be tackled and how we can start to plan around how they can help the community members with these health issues. And so we ran a couple of workshops, 2 workshops actually last week. And our workshops are really aimed at introducing ourselves. And in particular, we divided these workshops into a youth development focused workshop and another health focused workshop. And so we needed to introduce ourselves to the people in the room, but also find out who's missing so that we can get a good sense of, who really are the people that we need to be talking to and why. And so that was quite positive because we particularly invited youth leaders or leaders of NGOs and CBOs and faith-based organizations that deal with health in a variety of ways. And that was important for us because, well, at the end of the day, limited resources, we couldn't have a town hall, but the leaders themselves are the ones that are really going to carry our message well to their constituency. And so it was important to really introduce ourselves to the leaders. And then part of the discussions that we had asked them, could they give us recommendation of the type of person that should represent the community in this community stakeholder group. Again, we had really positive discussions, and I'll talk a little bit about that on what was really said around that one. And so then there were also a variety of questions that we had put to the group after we had done our own formal presentations. Questions around, advices on these kind of topics because we really want to do proper community engagement work. So For instance, question 1, we asked them useful and appropriate methods for community engagement activities during this pilot phase. And a lot of the comments that came through were pointing us to, look, if you design activities, make sure, number one, you're engaging with people where they are. There's no point in trying to replicate another forum. So go to where the community members are already meeting. If it's a Stockville, if it's in the schools, if it's an adult basic education and training class, where people are meeting is best where you're going to be able to find them and introduce yourselves in that forum. But obviously it means you need to now engage better with those people who convene them around those meetings. And so that's really our takeaway from that. And then obviously with our activities need to be very appropriate to the target. So if we're talking health to an age population or an age group, so you need to design something that is specific for them. If you want to talk to young people, design something that is specific. When we spoke around who should sit in this community stakeholder group and why, what we were looking for there is actually people that, a profile of a person who's best to really represent the community in this. And what really came out was it's best that we find people that already have existing networks. Even if you come representing an organization or your NGO, you need to have been working within a network of organizations for you to be the right person to sit on this kind of group, so that you don't really represent your own mandate limited to your organization. And that also allows us to have broader reach, because through that individual, that member in the CSG, they'll be able to reach the other organizations and the broader community that we need to reach. So that came out very strongly there. I'm looking at issues around threats and opportunities or challenges to community engagement. Look, what really came out strongly there was this issue of safety and security. And fortunately, in one of the workshops, we actually had the Jabulani police station captain who actually also attended, and the community policing forum that attended. And that was great because we could now start having engagements with them on how does one take a project like ours and ensure that whatever work it's doing, it's going to be secured, but also the people that we are going to be servicing don't feel any kind of threat or worry around their safety and security when they, for instance, see our health advocates walking around the streets of Jabulani and surrounding areas. And what really came out of there strongly was we need to position ourselves with organizations that are trustworthy in the community. And we need to communicate that we are a trustworthy entity. And so this issue of brand really comes in strongly. And a lot of the conversations were around, look, Wits University is a very strong brand, it's a known brand, and how do you leverage on a brand like that, for instance? But more so, whoever you're partnering with on the ground, you need to make sure that their reputation does not harm your work. Because ultimately, they are known for something, find out what that is, and make sure that whatever they are known for is not going to harm your efforts. So that was a recommendation from that discussion. And then on the fourth question, the type of activities we can plan to run in the next couple of months that address health issues in the community, well, there's a variety of those. It was interesting to see that people are actually interested in doing workshops, events, competitions of sorts around nutrition, because they still realize that good nutrition is something that leads to better health. And so it was a cooking event that is linked to food gardening and so on in the community. That is something that is positive. It leverages on other resources in the community, but it also brings the community very close around this issue of living a better life, through eating better and then becoming healthy. So those are just some of the the issues that we discussed in the workshops. The attendance of these was, like I said, it was really looking for people who are leaders or activists, right, of youth development and health-related issues in the community. And so we had made sure that each workshop was designed specifically to talk to either youth development or health, and simply because an agenda like youth and health is far too broad, and it was easy to just manage the group if we had to divide them neatly like that. And certainly going forward, we're thinking of following a similar model. But we really would like to have a specifically focused workshop looking at the health professionals or healthcare professionals, probably sometime early next year, because that is a group that we need to engage also separately to have our own focused discussions with them. Safety and security sector attended, which was really important, and I made comments around that. You know, we had youth leaders from the arts to community development in general who attended. And it was good to also see that, you know, your community arts groups saw the benefit of disseminating our messages through arts. And so we already know that we've got dissemination partners on the ground that we could leverage on when it comes to doing that kind of work. And so next year, definitely we are doing more community engagement work. And we look forward to touching base with a variety of organizations through the people that we've already been in touch with, so that we can build this community around us. So that's all for me, and thank you very much for this time.
Thank you, Letu. Really appreciate that. And the time, and thank you, Lisa, as well. Letu, a question that was asked, perhaps, from Dr. Ray Bila. He asks, have you engaged with nurses in the local community? I don't think you mentioned it. I'm sorry, with churches. Have you been able to engage with any churches?
So certainly the invitation went out, and they haven't responded yet. Right. But definitely that is the thinking, that we're going to be engaging with the faith-based community. We did find out that they actually run a variety of health-related programs.
Yes.
So that is exciting for us to find out, and we're going to be touching base with them. One of the participants in our workshop actually mentioned that he is one of the people, he called himself the kingpin when it comes to the churches. And so we thought, well, here's somebody who's got a network of churches around. Through him, we're going to be able to convince them on sessions.
Beware of the politics if anyone says I'm kingpin.
I'm sure. And we were definitely aware.
Sure. Well, thank you. I think that was very useful. I must say, Lisa and Letu, and I think that there's opportunity for you to link up with a lot of efforts within the public service as well. The ward-based outreach team is definitely there. There are about 550 ward-based outreach team or community of workers across Soweto. They don't cover the entirety of Soweto. I think we also have a meeting once a month. I'm responsible for clinical governance in Soweto, and we meet with both local and provincial government and managers. One is this Friday. If you can be there and brief people about it, we can talk about the project and also how it unfolds across the Soweto area, because we are talking about similarly in the public service to strengthen the capacity of community health workers in the district, in the sub-district starting. So I think it would be very helpful to link efforts up and strengthen it. One of the questions I have very quickly, if you could answer it, are these health advocates actually paid anything, or is the trainings essentially their sort of return for the 12 months of data collection? Any stipend, and what is that amount? Because I think that might represent a challenge going forward. If you, just a quick question about that, Lisa.
So yes, they do receive a stipend when they're with us and when they do this training. I think one of the key findings from HealthT was the young people really needed financial improvement in their lives while they were trying to get better education opportunities in order to really think and to do big things with their health, make big changes.
Yeah. And what is the stipend amount, if I may I just ask, because the public service at the moment has gone from 3,500 per community health worker per month to 8,500 now that they've been absorbed into the public service. Just a question about that and how that might fit together.
So while they're in training, they receive a training stipend of 3,500 per month.
Right. Okay. Well, I think that would be one of the things that crossed my mind is we could consider doing that training with the community health workers as well, and linking them up in some ways, finding ways to strengthen that capacity, which is formal and there and consistent. So I think that would be something to talk to. There have been a number of efforts, and on Friday we've invited one or two of them to come through where they said, they from Barra, that they said they could do some training for community health workers and develop that capacity. And I think if you can come, it's at 9 a.m. at Lillian Ngoyi, just in the auditorium. And if you can join it, I think it would be really good. So another question from Ms. Mbele and Tommy Zodwa is, appears good work is done mostly in Soweto. What do you think about broadening to other areas like East Rand? I think from what I can see, you're doing it in Jabulani, and it would be quite a stretch to get it to the rest of Soweto. I think the key is that this is being a project. What we should be looking at is how we strengthen the public service to deliver on these kind of things. And I think that's exactly the point. Expectations will be as well, can you come to my area? And I think that is not sustainable, I imagine, as a research project goes. So any comments in reply to Tommy Zodwa and Leto? Yeah, please.
Definitely. So you're absolutely right. It is a massive undertaking in Jabulani. The partners that we're working with, so Amandla and Safe Hub, already have a number of other centres around the country, and they're looking for ways for us to work with them to implement health more strongly in those centres. There's a very big sports and wellness focus, but not so much on basic health. So we are looking at opportunities to start doing something, maybe similar in those centres they already have. I think they're in Mitchell's Plain, in Khayelitsha. There too. Where are the other centres?
One is being set up in Alex.
Mm-hmm.
So, I mean, that's really what we have to work with at the moment.
Yeah, and I think that, as projects go, we should find ways to strengthen the public service, because that's where tax money is going. That's where things can be expanded. And we should be finding ways in which we help it to work better. And I think there's enormous amounts of money being spent on community health workers. The outcomes are not as promising. They're certainly useful, but they're nowhere near what I think is good value for money emerging from the community health worker program. So I think we need to make sure that program is strengthened considerably, especially now that so much extra resources being thrown at it. Thank you very much. I think it speaks to the issues we raised earlier about the opportunities for collaboration and the way in which we can synergize better and be able to get the outcomes that we need. And I think this is an example of what we could do more better in future. And I think let's hope we can work on that. So for Friday, if you can, I think it's a unique opportunity. Hopefully we get that meeting with managers after the COVID break, that they do come and we can actually talk to some of these issues. I don't see any more questions, and I think it's getting late in the afternoon. Thank you very much. Thank you, Shane. Thank you, Lindsey, Lisa, and Letu. We really appreciate the effort, time that you've spent with us. Thank you for sharing this wonderful work. I'm not sure that there's one more question. Sorry. Seshlule asks, I know of a Christians in Action. I suppose they be one door into the engagement with faith-based. So I think, Letu, you've got Christians in Action group that you could perhaps Google or see if you can contact Seshlule. Moyo on the call, on the webinar to find out more. So thank you very much for that, Seshlule. Thank you all very much. Take care. Be safe. Keep well. Enjoy your weekend. Bye-bye.
Many thanks, Shabir. Thanks so much for your invitation and your initiative in getting us conversing around these topics. It's much appreciated.
Thank you for coming.
Bye-bye,
Take
everyone.
Care. Bye-bye.
Bye.
Enjoy your leave, Shane.
Thank you. Take care.
Bye.